Garoto. Mhm. Pe apa, pe apa.
Good morning, dear colleagues. Welcome to our morning session. I will open the session with the first presentation, topographical anatomy of the pelvic girdle and hip. I'm giving the floor to Professor Novakov.
Good morning, everybody. I hope you had a nice yesterday social program after the session. So I'll start today's session. I'm the first, so I should say something more. I'll start with a verse from the Bible, paraphrasing it. In the beginning was the Word. I will say it, in the beginning was anatomy. So we start with 2 anatomy lectures now. We are bipedal creatures, and we are unique. We must stand upright. There are some few animals which are also using just 2 legs, but it's not the same biomechanics as ours. 4 design consideration for bipedal gait and upright posture. Stability in upright posture, ability to raise and control the trunk over hind limbs, ability to balance on one leg, walk with the feet underneath the body. Stability comes from our lower extremities, which are larger and heavier than the upper extremities, so the center of weight is lower. And we can give an example with a famous toy in the previous century. Wibbles wobble, but they don't fall, while the eggs do. Hip joint is a acetabulo-femoral joint, and pelvic girdle is a bony circle, a bony ring with several bones. That's the sacrum and 2 hip bones. Hip joint and pelvic girdle, they work together, much like shoulder and joint girdle. Pelvis moves in response to trunk and to high movements. It's an extremely stable joint. We have the strongest ligaments here in that area, ligamentous structure. Muscles were mentioned already. There are powerful muscles around the hip, and the deep acetabulum, which collects more than 2/3 of the head of the femur. Gluteal region lies between the imaginary line that connects the iliac crests and the gluteal fold. The contents here are the ligaments. We have also some additional areas like the foramina, greater and lesser sciatic foramen. Muscles are listed: vessels, superior and inferior gluteal branches of internal iliac, and the nerves are the branches of the sciatic plexus. The 2 main ligaments here, powerful ligaments, are the sacrotuberous and the sacrospinous, which stabilize the sacrum and prevent back rotation under the weight of the vertebral column and the body. The pelvic muscles are the biggest and most powerful body muscles. They stabilize the hip joint and support body during standing and movement. They arise from the pelvis and attach to the thigh, organized in 2 groups. The anterior group includes the psoas major and iliacus, which when they are going under the inguinal ligament, they are named as iliopsoas muscle, which attaches to the lesser trochanter. The posterior group includes the gluteus muscles, gluteus maximus, medius, and minimus, placed in a different level. The most superficial is the maximus. The maximus gives the ability to raise and control the trunk over hind limbs attached to this sacral area. And the ability to balance on one leg are the well-developed hip abductors, gluteus medius and minimus. With the next two slides, I just want to recommend you to go into the detailed anatomies. Normal and standard anatomy is not always the same when you open your patient. So in the first slide here we can see with asterisk the distal attachment of the gluteus medius as a variation, and the second one, gluteus medius, attaches to the tendon of piriformis. These pictures are taken from the Human Anatomy Variation Encyclopedia of Bergman and Tubbs. And variability is the law of life, never forgot that. And you shouldn't be surprised when you see differences from the class of anatomy, the first and second year. Posterior group muscles include also tensor fasciae lati. The piriformis, which is a lung muscle, and we'll say a few more words later in the next slides. The two gemellae, the obturators, internus and externus, and quadratus femoris. These are lateral rotators. You can see them on this drawing. Piriformis is the triangular one, and you can see the sciatic nerve which goes under. That's another picture of the area with the piriformis muscle. Piriformis syndrome is well famous in the pathology. There is a pain in the region of trochanter, in the gluteal region, and along the sciatic nerve. It could be due to traumatic injury causing hematoma that compresses the piriformis muscle. It's not impossible that piriform syndrome could be due to the relation between the piriformis and psoas major. This classification of 6 types of relation given in the last century by Beaton and Hansen. And you can see it with the pictures here. The biggest percentage is the first one, which we consider normal, and we teach the students with that one. In 90%, you can see the number in this systematic study of our Greek colleagues from Athens. The second one in 8% is when we have an early division of common peroneal nerve and the tibial nerve, and the common peroneal pierces the piriformis muscle. And in this case, also in the fourth one, you can see, and the third one, that we have this piercing of the piriformis that could also be a reason for compression of the nerve. 2 foramina were mentioned as additional regions in that area. The greater sciatic foramen, which is surrounded by the 2 ligaments, and the greater sciatic notch, and the lesser sciatic foramen by the lesser sciatic notch and the sacrotuberous and sacrospinous ligaments. The greater sciatic notch transmits most of the structures of the gluteal region, including piriformis, sciatic nerve that we already mentioned, other branches of sacral plexus quite posterior, cutaneous, the superior inferior gluteal nerves and vessels to pudendal nerve, internal pudendal artery. That's the lesser sciatic foramen, with the tendon of the obturator internus goes around there from the pelvis to the gluteal region. There is a small branch of obturator internus which is supplying the muscle. Pudendal nerve returns back to the lesser sciatic foramen in the pelvis, together with the internal pudendal vessels. The nerve supply of the area is by the lumbosacral plexus. Lumbar plexus arises from L1 to L4, and the sacral plexus from L4 to S4. The lumbar plexus branches are the femoral, obturator, lateral femoral cutaneous, genitofemoral nerve. Sacral plexus includes the main nerve and the biggest nerve of the body, that's the sciatic, superior inferior gluteal, posterior femoral cutaneous, and pudendal nerve. The vessels in the area, we'll do them last because they're important for the clinical practice. This is the internal iliac artery, which divides into two trunks. Posterior one, which is bigger and larger and continues in the suprapiriform foramen above the piriformis muscle, like a superior gluteal artery, and the anterior trunk, anterior division, continues down under the piriformis as inferior gluteal artery. You can see them on the picture. That's the inferior gluteal. Arteries of the pelvis and thigh include also the external iliac, which gives two branches above the inguinal ligament and continues as femoral. More important are the femoral branches here, for which surround the neck of the femur and supply the joint, like medial and lateral circumflex arteries, and the deep femoral artery with the perforating branches. And we're closing this presentation with the anastomosis, which are important for you. Trochanteric anastomosis is around the greater trochanter, and the cruciate anastomosis, you can see them here. That's the trochanteric anastomosis, which includes the descending branches of the superior and inferior gluteal arteries and the ascending ones of the circumflex femoral arteries, medial and lateral, and the cruciate anastomosis with the inferior gluteal, ascending branches of the medial and lateral circumflex, and the first perforandus arteries also supplying that anastomosis. So we have anastomosis between the iliac vessels and the femoral artery. The head of the femur is commonly affected by vascular disorders. This is due partly to the intra-articular position of the structure. The nature of femoral head results in depending on the retinacular blood supply. The supply is derived from anastomosis of larger vessels supplying the hip. You can see the arteries for the neck. Don't forget the artery that goes with the round ligament of the head. And I will end this presentation with that slide. The femoral head is vulnerable to vascular necrosis in the presence of femoral neck fracture, since the vessels that are shown are easily ruptured without injury. Thank you very much. Have a nice day.
Thank you. Thank you for your presentation. Let's continue with the next speaker, Baltaziev, Topographical Anatomy of the Knee and Ankle Foot.
Good morning, everyone. I will present some topographic features of the knee joint, articulatio genus. First, the articular surfaces. Both condyli femoris and facies patellaris femoris, they are convex, and the radius of the medial condylus is smaller than these of the lateral one. Next bone, which comprises the knee joint, is the tibia, of course. Both superior articular surfaces have an elliptic shape, slightly concave and inclined slightly posteriorly. The patella, the third bone has a surface, facies articularis patellae, which is divided into two articular facets. The lateral one is largest and the medial one is smallest. Menisci. The auxiliary elements of this joint, they are two in number. The lateral meniscus, it has a shape of incomplete ring, and the medial one, which is having a shape of crescent or sickle. Now the classification of different variability of the lateral meniscus. This is the normal shape. This is the incomplete discoid shape, and this is the complete discoid shape. It is called also the type of Weisberg. Watanabe has presented a classification about the third sort of discoid meniscus. The first type is complete discoid lateral meniscus, but here is present the meniscotibial attachment by connective tissue, of course. And I will add, if you see this blue arrow here, it is showing the posterior meniscofemoral ligament, which connects the posterior horn of this menisc to the medial internal surface of the medial condylus. So, and the rim here, articular rim, is stable. The second type, incomplete discoid lateral meniscus. Presence of the same attachment between the disc and the tibial articular surface, and also a presence of the posterior meniscofemoral ligament. And the rim, the articular rim, is also stable. More interesting is the third type according to Watanabe, complete discoid lateral meniscus, but absence of the meniscotibial ligament here. In this case, the posterior horn is attached to the internal surface of the medial condyle only, and therefore the rim is unstable. Menisci and the synovial membrane. I remember that the cartilaginous connective tissue hasn't got any autonomic blood supply. The supply of oxygen and glucose is through the neighbor loose connective tissue. And in this case, this attachment here, the synovial membrane to the peripheral edge of both meniscs, is very important for the vascularization of the menisci. More vascularized is the peripheral part than the internal edge, and so this is the reason to recover more successfully the peripheral part in comparison to the internal part or internal edge. So, attachment of both meniscs. First, the medial one, this one, the anterior horn, this is the anterior horn of this meniscus, is attached to the anterior intercondylar area, but in front of the attachment point of the anterior cruciate ligament. And look at its posterior part. It is connected to the lateral meniscus through the ligamentum transversum genus, if it is present. The posterior horn of the medial meniscus, it is attached, of course, to the posterior intercondylar area, but in front of the attachment point of the posterior cruciate ligament and behind the attachment point of the posterior horn of the lateral meniscus. Attachment of the lateral meniscus, this one, incomplete ring. It has the shape of incomplete ring. The anterior horn is attached in front of the lateral tubercle. This is the intercondylar eminence. Posterolateral according to the insertion point of the anterior cruciate ligament. The posterior horn. The posterior horn is attached on the posterior side of the same tubercle, but in front of the attachment point of the posterior horn of the medial meniscus. And now this ligament, ligamentum transversum genus, the transversal ligament, it is also variable, this one. It attaches the anterior horn of the medial meniscus to the convex margin, anterior convex margin of the lateral ligament, lateral meniscus, excuse me. So, meniscofemoral ligaments. The anterior meniscofemoral ligament, this one, this small bundle, this thin bundle, is called a ligament of Humphrey, and it attaches the posterior horn of the lateral meniscus to the internal surface of the medial condyle, but it runs anteriorly according to the anterior crucial ligament. And the next one, the posterior one. This is the posterior one. It attaches the posterior horn of the lateral meniscus to the medial condyle, but it runs behind the posterior crucial ligament. So, attachment of both meniscs to the collateral ligaments. Firstly, look at this. This is the medial collateral ligament, and the medial meniscus is attached safety to this ligament. But if we have a look at the other side, at the lateral side, between the peripheral edge of the lateral meniscus is a short distance to the lateral collateral ligament. I used the word distance, not gap, because it is not gap, it is full of loose connective tissue, of course. Which is the reason of this difference? This is the reason. The attachment, the origin of the popliteus muscle. Its origin tendon is attached to the lateral epicondylus of the femur, and it runs between the lateral collateral ligament and the lateral meniscus and the peripheral edge of the lateral meniscus. So, from anatomical point of view, these are the reasons that the medial meniscus is more stable or more stable attached than the lateral one. Thank you for your attention.
Thanks to Professor Bartagiev for the detailed and valuable presentation. The next speaker is Professor Stefanov with topic Principles and Methods of Treatment of Meniscal Injuries.
Thank you very much for opportunity being here. After you have heard about the anatomy of the meniscus, let's talk about what to do when the tear happens. Meniscus is a very important structure in the knee, and there is dramatic progression in the way we understand the meniscal function in the last 50 years. So before we thought there was this is a useless structure, but now we know that it's very important for load distribution and function of the knee. And if we perform a partial meniscectomy, we have a really big problem in the function of the knee joint on the long-term basis. You heard already about the meniscal anatomy. There are two meniscus with anterior, posterior horns and the body of the meniscus. So it's attached anteriorly and posteriorly in the medial and lateral tibial condyle. Especially for the lateral meniscus, it's important that it's not attached the full part of the meniscus, but in the middle part it's loose. What about the blood supply? Regarding the meniscal healing and meniscal function, blood supply is very important, and it comes, as you see here, from the periphery with lateral and medial genicular artery. And according to the blood supply, we divide the meniscus in three zones, which is with the red zone, the capsular zone with the best supply, red-white zone with limited blood supply, and white zone where the meniscal healing is could be compromised. These are the structure of the meniscal fibers. You see here the orientation of the collagen fibers. So we have longitudinal orientation, which enables the load distribution in the knee. After that, these collagen fibers affect mostly also the trauma of the ruptures of the meniscus. That's why we divide these ruptures according to localization, which are the three main types of meniscal lesions. One is in the front, the middle, and the rear part. Also, we have classification of the lesions of the meniscus according to the tibial plateau. Could be vertical or horizontal tears. Also, according to the rupture propagation, you see here three types: the longitudinal, oblique, and transverse tears of the meniscus. Sometimes we have a complex tear called bucket handle tear, which is affecting a big part of the meniscal body, and also very often seen a parrot beak tear. As I told you, meniscus is a very important structure in the knee, and even in 1936, King described the development of knee arthritis after total meniscectomy. Also, Fairbank described similar changes in the knee after meniscal removal. So today we know about the meniscal function, and this is very important functions as described here. Improves the passive stability, increases the congruence of the joint, prevents synovial impingement, and also limits the extreme movement in the knee, flexion and extension, increasing the contact area. And also very important one, this is regarding the arthritis, it reduces the contact load on the articular cartilage. This is on this scheme, you can see how load distribution is performed by the meniscus between round and flat condyles of the femur and the tibia. Healing capacity is the most important thing when we speak about meniscal repair, and of course with the aging of the patient, this healing capacity is reducing. Very important is that peripheral vascularized part of the meniscus is with a big healing capacity. This is exterior road, so how it works from the vascularization, but also we have internal way the meniscus to heal, so it is performed by meniscochondrocytes, which can produce tissue, matrix tissue, which makes the repair of the meniscus. So, especially for meniscal recovery, we need to know where is the damage. Is it on the peripheral part, or it's in the central or articular part? What we need to do the meniscal repair? We need to know about the surgical skills. We need to know the potential of the injury to heal, and we also need to know the biomechanic factors. Today we think that longitudinal tears in the vascularized periphery should be repaired, and in the other cases we have to see the patient, the age, the expectations, and all these things regarding meniscal repair. So what about the recovery and the healing potential? We need stabilization of the structure to give the possibility the meniscus to heal. What kind of factors should we have on mind when we repair the meniscus? Of course, magnitude of the defect. If it's a small one, up to 1 centimeter, it is even possible to heal spontaneously without surgery, just sport limitation and sometimes bracing. Age of the patient is very important. In the young age, possibility of the meniscus to heal is much bigger than in the middle or older age. And also, if we treat the injury in acute basis, the potential of healing is much bigger. Meniscal suturing, which is the most common arthroscopic technique of meniscal repair, we have 3 of them. It is outside in, inside out, and all inside. Outside in technique is performing the suture from the outer part of the meniscus to the joint. Inside out is the opposite, from inner part to outside. And these are the devices we perform these techniques, such needles and sleeves for doing the suture. All these techniques in the modern knee surgery are performed by arthroscopic guidance. All inside technique, this is the most experienced technique. You need special guides, as this here shown on the picture, also special needles for doing this, or arthroscopic pusher to lock the knot, and special delivery systems, which is from different companies, different design. This allows to approach the meniscal lesion from inside the joint. So we refresh the rupture with the rasp, and then you see the steps of the suturing technique with the needle inside the meniscal lesion, tying the knot on the meniscus. You see different steps here, and after that you have this suture as shown here. So this stabilizes the structure and gives the potential of the meniscus to heal, which is very important for the future of the knee. The placement of the suture is very important, and we know that vertical sutures are much better as a stability compared to horizontal sutures. This is because of the orientation of the collagen fibers. If the suture is not possible, we go for the meniscal resection. There are important principles for meniscal resection. The most important principle is to preserve the meniscus, to remove only unstable parts and not to remove all what is damaged. You see here on the picture how, for example, looks the removal of the meniscus. So we leave all possible part of the meniscus, even it's with some damages, because it could play the role of low distribution in the knee joint. Very important and very interesting topic is the meniscal transplantation. probably you don't know, but I can tell you that the Italian Orthopedic Society is one of the pioneers worldwide for meniscal transplantation. We have artificial meniscus, which is collagen meniscus implants. It is the idea is because when sometimes it's not possible to save the meniscus, and if it's lateral meniscus, it's very important to put something in the knee, and this is the collagen meniscal implant. This is how it looks like. It's similar to the meniscus on the form, and you see here how it looks like on a clinical case. Total meniscectomy performed before for a patient. We size the defect. We size the defects, how big it is, and after that we suture the meniscal implant, which is also performed by arthroscopy. You see here how it looks 6 months after implantation and 2 years after implantation. So as conclusion, I can tell that we are convinced that the principles and methods of treatment should be applied blindly and with academic purpose, but should always take into account the individuality of each patient. Each patient needs his or her personal treatment. The joint decision making of the method of treatment by doctor and patient, and the patient conviction of the correctiveness of the therapeutic procedure is the basis for the success of any treatment. So our society, knee society, has this speech for the meniscus: save the meniscus when possible. Thank you for the attention.
Thank you. Thank you so much for your presentation. So the next presentation is contemporary approaches for infection prevention and control of surgical site infection. Vacheva Dobrevska.
Dear professors, dear colleagues, current approaches to the analysis of surgical site infections have changed considerably since Lord Moynihan remarked more than 100 years ago that every operation in surgery is an experiment in bacteriology. Despite the remarkable progress in the use of surgical techniques, ergonomic changes in the operating room, knowledge of the SSI pathogenesis, the widespread introduction of antibiotic prophylaxis, SSIs continue to be among the most common healthcare-associated infection, with a major source of morbidity and mortality, increased length of stay, and increased need for postoperative intensive care, and finally, increased the financial burden. The mortality rate in patients with SSI was 6% compared to 2% in patients without, and in patients with a fatal outcome after surgery in 37% of cases that was directly caused by SSI. Here we have a different percentage proportion of infections by type of procedure. And this table originated from the ECDC Stockholm protocol for point prevalence survey of healthcare-associated infections. And here we can find the definition of healthcare-associated infection. In one side, we have the onset of HAI, and the other side, the case definition of active HAI. Basic definition is that the onset is day 3 onwards after patient admission, but we have several exceptions, and first exceptions, they are SSI. On day 1, day of admission, or day 2, if SSI criteria met at any time after admission, including previous surgery 30 days or 90 days in case of implant. You know this definition of three groups depending on the anatomical area they affect. And I include from ECDC protocol the definitions from superficial incisional, SSIS, deep SSID, organ space SSIO. You will have an access to this presentation later. I can come back in details in these definitions. The definition of bone and joint infections and bursa. And now we have analysis from third point, European point prevalence survey of healthcare-associated infections and antibiotic use in European Union. And you can see that the result is 7.1% of prevalence of HI. After national validation PPS, the percentage grow to 8%, and we have worse result. You can see that we have 300 patients with at least one HI in any given day, and totally 4.3 million patients with HI, and about 5 million cases, infection episodes per year. Concerning surgical site infections, they are 16% from all registered infections, and very interesting, the left side of this figure, this HI present on admission. It means that this patient has another hospitalization on the same or another hospital, obtained healthcare-associated infection, and when you readmitted this patient, you can diagnose the infection on first day. 26% of infections present on admission are surgical site infections. Etiology, the most common, Staphylococcus aureus and epidermidis, especially MRSA, both are very dangerous. Beta hemolytic, Streptococcus pyogenes group A, Agalactic group B, Enterococcus, all familia Enterobacteriaceae, including carbapenem-resistant, Klebsiella, E. coli, etc., Pseudomonas, and anaerobes. And you know that the treatment is very limited in case of methicillin-resistant staphylococci, vancomycin, and linezolid, and we already have vancomycin-resistant MRSA. Surgical site infections are a potential complication associated with all procedure and are the most preventable HI. Two paradigms, we have a role of the patient microbiome in SSI. During the last years, most attention is especially on patient microbiome, and that's why we are doing this screening for carriers. And SSI development involve subtle interaction between microorganisms, macroorganisms, in which the surgeon and the environment can play an important role. The second paradigm is antimicrobial resistant and surgical antibiotic prophylaxis. Patient factors as a high risk of infection. If a patient has drains, inhibition of neutrophils, bacterial attachment and biofilm formation, implants, and sutures. Orthopedic SSI and biofilm formation, in order to survive, many bacteria form dense colonies called biofilm, which adhere to inanimate or living surfaces and surround themselves with a matrix of extracellular polymeric substances they manufacture. This protects them from external stress and from neutrophils, as well as from antimicrobial agents. Biofilm-associated SSIs don't respond to conventional antibiotic therapy, and in the prevention of this process of SSI, it's very important to stop, to prevent the bacterial adhesion to the implants or to patient's organ. How bacteria and biofilm might be distributed in a periprosthetic joint infection. Here we have an example. Biofilms can grow on the prosthesis components, the surrounding tissue, and the fibrous sheets. There can be migration of bacteria between this niche, and if bacteria in one niche are eradicated by debridement or antibiotic therapy, there is potential for the repopulation of pathogens from the other niche. The diagnosis of infection, orthopedic SSI can be challenging. We have 3 cases here. In case A, we have a positive microbiological result from the material taken by puncture. In patient B, in B cases, the microbiology results stay negative, but in C is the intraoperative image from B case showing purulence and slime in the joint space and an intraoperative positive microbiological culture. The D case is completely microbiology negative, but the authors registered elevated C-reactive protein over 20,000 white blood cells with more than 90% polymorphonuclear leukocytes, and this is the basis of diagnosis. And the imaging of periprosthetic biofilms using quantum dot labeled antibiofilm antibodies. You can see the staphylococci adhere to various suture materials and biofilm formation, and here is the same also in the suture. The biofilm is formated from Corynebacterium mcginley. New agents to prevent biofilm formation use a different kind of polymers, releasing antimicrobial agents, graft with special coating, wound dressing, and spine. The solution, use of antimicrobial preparation, not antibiotics, to help protect the surgical suture, incision site, and patient from infection. The mechanism of action appeared to be related to inhibition of colonizations, adherence, and thus prevention of biofilm formation. The WHO, CDC Atlanta, and American College of Surgeons have recently published in 2016 guidelines for the prevention SSI. Despite clear evidence and guidelines to direct SSI prevention strategies, compliance is unacceptably poor. You have the brilliant lecture from yesterday about the objective of this guideline, and I will show only 3 topics. The first is especially about laminar flow ventilation system in the context of operating room. The recommendation is that the panel suggests that the laminar airflow ventilation system should not be used to reduce the risk of SSR for patients undergoing total arthroplasty surgery. Strong recommendations against antibiotic use, against washing the wound with an antibiotic, against antibiotic prophylaxis in the presence of drain, and against the prolongation of antibiotic prophylaxis after completion of the operation. In all of these cases, very quickly bacteria develop resistance to the antibiotics, very quickly, and we lost this antibiotic for treatment for the future. The panel suggests that antibiotic incisional wound irrigation should not be used for the purpose of preventing SSI, and especially about triclosan-coated sutures. The panel suggests that the use of triclosan-coated suture for the purpose of reduction the risk SSI independent of the type of surgery, with very good effect. Excellent effect in vitro and in vivo. These triclosan-coated sutures are very, very important because you can see the stop of bacterial growth around the suture in vitro. Do SSI reduction bundle work? You know these bundle approaches with 3 to 5 small rules that can be repeated for each patient in any procedure every time. Yes, this publication with a review of 13 studies, 8,000 patients show if you use care bundle, you register about 7% of SSI, without care bundle, 15%. And I show several bundle approaches. First, in the preoperative phase in surgical ward, ensure that the clinical risk assessment for MRSA and the screening for nasal carriers is undertaken, and decontamination after with mupirocin. Don't use hair removal routinely, don't use shavers. If you need, use clippers. Ensure that the patient has showered or bathed on the day of operation or the day before. Ensure that prophylactic antibiotics is prescribed as per local antibiotic policy, signed guideline for the specific operation category, and is administered within 60 minutes prior to the operation, blade to skin, and 120 minutes for vancomycin or ciprofloxacin. Ensure the single use of 2% chlorhexidine, especially for skin preparation. The patient's body temperature is maintained above 36 degrees. Diabetic patients' blood glucose level is kept less than 11 millimole. Hemoglobin saturation is maintained above 95%. Use triclosan coated suture and ensure that the wound is covered with a sterile wound dressing. And post-operative, ensure that the wound dressing is kept in place for 48 hours after surgery. The aseptic technique is used, and ensure that hand hygiene is performed immediately before every aseptic dressing change. And you know that the hand hygiene of medical staff is a basic stone on infection prevention. Thank you for your attention.
Thanks to Professor Dombrovski for the interesting and valuable presentation for the practice. The next speaker, Professor Minutilou, and the topic is pelvic ring and acetabulum approaches.
Good morning. The pelvic ring is formed by three skeletal segments: the sacrum coccyx, the iliac bone, and in each of these segments we can identify three parts: the ilium, the ischium, and pubic. These three skeletal bones are connected posteriorly by sacroiliac joint and anteriorly by symphysis pubic. The three bone segments are connected by strong ligaments, anterior and posterior. The characteristic architecture of the ligaments of the pelvic ring let adequate transfer of the load from of the body to on the leg. On the lateral surface of each iliac bone there is a depression, the acetabulum, with the femoral head form the hip joint. This depression is accommodated between two sturdy branches, the anterior column and the posterior column. The acetabulum presents two walls, anterior and posterior. The classification of the pelvic ring, according to Younger and Burgess, are based on traumatic mechanisms. We so identified lateral compression, anterior to posterior compression, and vertical shear. According to the traumatic mechanism of the position of the femoral head inside the acetabulum, we can observe two kinds of pattern of the fracture: the elementary lesion and the associated lesion. The imaging of the pelvic ring lesion are based on X-ray and with the TC reconstruction. The X-ray according to Pennell and Tile. The imaging of the acetabular fraction according to Letournel and with the anterior to posterior operatory oblique view, alar oblique view. And the TC constriction, we can identify a lot of line. Today, a lot of this lesion needs a surgical treatment, so we can identify 4 approaches for pelvic lesion and 3 approaches for acetabular fracture. The indication for the transilio-sacral screw are lateral compression, posterior compression, the 1 or 3 type Burgess classification, and the vertical shears, and associated with the anterior reconstruction. The approach is percutaneous and it is fundamentally identify the corridors in which we can put the screw. Radiological landmarks, we can perform the anterior posterior view for determine the normal or the morphic sacrum, and the inlet outlet view, so we can identify the corridors, and overall the lateral view that identify the anterior slope that is fundamental for the L5 root position. With patient in position or prone supine on a carbon fiber table with C-arm, we can perform the position of the Kirchner wire as a guide, and so we can put the screw in sacroiliac lesion perpendicular to sacroiliac joint, and with the fracture of the sacrum perpendicular to fracture line. Sometimes it's very important because we have the possibility of the mistake, and so we have the non-correct position of the screw with the L5 lesion root. The approach of the pubic symphysis are the indication for the ectasis of the or destruction of the symphysis, fracture of the anterior pelvic ring, and fracture of the pubic rami. With patient in supine position on carbon fiber operative table with the C-arm, we perform the overall inlet and outlet view. So we perform a horizontal incision according fine steel 2 centimeters above the pubic tubercle of 10 centimeters of length. So we can identify the linea alba. Incision the linea alba longitudinally, retraction the rectus abdominis laterally, the section of retrosymphysial region, taking care to avoid injury the urinary bladder and the prostatic venous plexus. Detach the rectus abdominis from the pubic tubercle. Anteriorly, it may be necessary elevate the rectal insertion from the pubic body to identify the obturator foramen. So we can expose the symphysis. The pubic ramming can identify laterally to the region of the iliopubic eminence. So we perform the reduction of the joint and the stabilization with the plate and screw. The posterior approach here, so ligament joint. The indication is the posterior stabilizing of the pelvic ring and the HS, this let the HS to the posterior ligament and the sacroiliac joint, and the posterior surface of the sacrum. With patient prone position, curved in the incision overlying the posterior iliac crest, following the crest distally to posterior inferior iliac spine. Skinning the incision starts 1 or 2 centimeters laterally posterior to the superior iliac spine and runs vertically or curved about 10-15 centimeters in length. The dissection of subcutaneous tissue are in line with the skin incision until the iliac crest. Sharply we detach the gluteus maximus muscles from ilium and elevate to expose it laterally as needed. During this subperiostal exposure, the posterior posterolateral ilium and elevation the gluteal maximum muscle is important to remember that the location of the superior gluteal vessel and nerve that are in this case at risk. The inferior gluteal artery, vein, and nerve exit to the great sciatic notch foramen and at the conage edge of the piriformis muscles and run upward to enter in the deep surface of the gluteus maximus. The alignment of the joint can be assessed by palpation through the great Shaktic notch with the finger dorsal to piriformin and the anterior sacroiliac joint. The closure is very important. Reattach the muscle gluteus to the medial fascia flap over the position of the posterior rhinum, subcutaneous to tissue, and skiral close in line. So we perform the approach to the accetabulum. We can identify 3 approaches, the one posterior and the 2 anterior. The posterior is cock and lung back approach, and this allows the visualization of the posterior column, posterior wall, and the retroacetabular surface. The cranial increment of this approach, we can perform a trochanteric osteotomy, and while the caudal expose detachment the quadratus femoris from the ischiatic tubercle to avoid the injury of the medial circumflex artery. With prone or lateral position, with the knee flexed at 90 degree with knee extension, so we reduce the tension of the sciatic nerve. The skin starts a few centimeters, the skin incision starts a few centimeters distal to lateral to posterior superior spine, continue the incision anteriorly above the great trochanter, and curve it distally along the tip of the trochanter towards the lateral surface of the femoral shaft until the middle shaft of the femur. Divide the subcutaneous tissue and incise the fascia in the proximally with the gluteus maximus and the iliotibial tract distally. Split the gluteus maximus in line with the fiber starting by great trochanter in proximal direction. Distally incise the iliotibial tract in line with its fiber up to the middle third of the femur. Expose the insertion of the piriform tendon, gemelli, and the obturator internal muscle. The Shaktic nerve lies posterior to gemelli and the internal obturator muscle, and anterior to piriform muscle. Detach the muscle, the gluteus maximus, 1 centimeter from its insertion on the femur, so this allows a less tension and easier mobilization of the gluteus maximus. Detach the internal rotator muscle, so isolate the piriform, place the suture at 1 centimeter lateral to its femoral insertion, and dissect the tendon. Reflect the piriform laterally to expose the retroacetabular surface of the greater Shaktic notch. So we can isolate the conjoint tendon of the obturator internus and the superior and inferior gemelli muscles. Incise them 1 centimeter laterally of the femoral insertion. Reflect this muscle to access the lesser ischiatic notch. Insert 1 retractor in the lesser Shaktic notch and 1 anterosuperiorly. Now, at this point, the posterior column is visible. The quadratus of the femur can be elevated from its origin. Better ischiatic to expose distal extent to position. So we have the image. For the closure wound, we perform a meticulous debridement of all tissue before starting wound closure. Remove the necrotic tissue and irrigate the anterior wound to decrease the risk of periarticular ossification. Reinsert all the tendon and the proximal part of the gluteus maximus. Perform the close of the iliotibial fascia, subcutaneous tissue, and the skin. The repairing of this tendon represents an additional risk of the femoral head vascularization, particularly through the conjoint tendon, where the passage of the needle into the strump may injure the medial femoral artery, which sometimes we can avoid this. The ilioinguinal approach, developed by Emile Retournelle, and based on cadaveric dissection, provides anterior access for the treatment of the fracture of the acetabulum. It let the exposure of the inner aspect of the denominator bone from the sacroiliac joint to pubic symphysis. The surgical exposure requests a development of 3 wound or interval, mobilizing the femoral and vascular nerve, spermatic cord in the male, and round ligament in the female. They are the key of the development of this wound interval. Articular reduction is done indirectly. It is based on the meticulous restoration of the extraarticular anatomy, since the joint cannot be directly visualized through this approach. The approach allows direct access to the vast area in the anterior ilium. Make with the patient in supine position, make a curve in incision, beginning posterior to the gluteus medius pillar and extend over the midline 1 or 2 centimeters above the symphysis. Exposed internal crest, beginning exposed in the internal iliac fossa, release the external oblique insertion from the iliac crest, taking care to leave the fascial periosteal cuff to facilitate the successive repair. In continuity with this release, expose internal iliac fossa subperiosteally, mobilizing the iliacus muscle. Then incise the external oblique aponeurosis and to lateral border of the rectus, pressing the canal to enter in the inguinal ring. The spermatic cord or round ligament are mobilized in the medial aspect of the wound. Medially, the transverse abdominis muscle is then released from the inguinal ligament. This release begins at the anterior superior iliac spine and progress medially to the conjoint tendon of the internal oblique muscle and the pubic tubercle. The lateral cutaneous nerve usually runs just deep the conjoint tendon in the internal oblique and transversus abdominis muscles, approximately 1 or 2 centimeters medial to the anterior superior iliac spine. The anterior part of the iliopsoas muscle is exposed in the lateral portion of the wound with the femoral nerve that lying on its anteromedial surface. The iliopectineal fascia is delimited by careful retraction of the femoral vase medially and the femoral nerve and the iliopsoas laterally. It's then divided distally under direct visualization down the pubic bone root. The iliopsoas is then retracted laterally, exposing the fascia attachment to the pelvic ring, which can divide softly. Once the iliopectineal fascia has been released, the true pelvis can be visualized from the internal iliac fossa. This limits the risk of vascular injury and also preserve the path of the primary lymphatic trunk on the lower image, which passes medial to iliac vein. So we can identify the 3 windows. The first window encompasses the anterior iliac fossa from the sacroiliac joint posteriorly to iliopectineal eminence anteriorly. This window is optimized with the hip flexion of the iliopsoas to relax the iliopsoas muscle. The second window lets the chest of the pelvic brim and the quadrilateral surface from the sacroiliac joint to the lateral third of the superior pubic rami. Medial retraction of the femoral vessel should be gentle and must carefully monitorized. The third window is the interior medial portion of the superior rami, and the symphysis can be visualized by release of the ipsilateral ramus in section. From the opposite side of the patient, we can see easily any retropubic vascular communication between the obturator vessels and external iliac vessels, the corona mortis. Such a retropubic anastomosis present in 40% or more patients are at a risk of being torn. They may require irrigation to allow the mobilization of the iliac vessels. The layer closure begins to repair the conjoint tendon in the inguinal ligament. A careful repair restores the floor of the inguinal canal, and the sternocleidomastoid aponeurosis and rectus stealth are then repaired, followed by a secure attachment to the abdominal wall originating on the iliac crest. Finally, perform an appropriate subcutaneous skin closure. The last view is the modified. So, describe for stopper the indication for this you can use to across such as the anterior column and when associated with the latest view of the excellent visualization on the quadrilateral surface. This approach allows the visualization of pubic symphysis, the anterior quadrilateral surface, and the anterior column. The patient in the position supine on radiolucent table, the surgeon stands on the opposite side of the fracture. A fenestrine incision is usually used placed above the pubic symphysis, divided the subcutaneous tissues in line with the skin incision until the exposed fascia and overlying the rectus both. Rectus fascia is incised longitudinally along the linea alba. Both billies of rectus abdominis max are gently retracted laterally. The medial part of rectus mass is partially detached from the upper and anterior part of the symphysis on the side of the fracture to allow the rectus to retract. The upper border of the pubic ramus identified and the blunted dissection using a finger carried laterally along the pelvic ring without incise the fascia. So we are exposing the carefully medial of the superior ramus, and the corona mortis are identified and ligated. This is a fundamental passage. Once the corona mortis vessels are identified and ligate, the periosteum from the superior pubic bone is dissected sharply using diathermy along with for deeper blunt dissection. The dissection of periosteum is continued laterally following the upper board of superior bone to the rectopelvic ring, exposes the bending of the iliopectineal eminence. At this point, the iliopectineal arc should be dissected from the bone. This enables elevation. The femoral vessels and the dissection is continued subperiostally, more laterally following the upper board of the pelvic ring. Now the interior internal surface of pubic has been exposed. At this level, the retro neurovascular bone is crossing the quadrilateral surface. A malleable rector retractor is used to protect the obturator vascular bundle on pelvic. With a Cobb elevator, the periosteum elevator, internal masses are elevated on the quadrilateral surface can be sufficiently exposed. In some cases, the artery bifurcates very distally, and so make this section very, very difficult. We can improve this expose with the additional window that are the same position of the first window of the ilioinguinal approach. So the anterior approach provides access to iliac crest, interior iliac fossa, and sacral arch. This is limited by L5 root that lies on the anterior surface at the sacral area, 1.5 centimeters medial the joint line. Thank you.
Thank you, Felice. Let's continue with the next presentation, importance of osteoporosis and drugs for its treatment on fracture healing. Ganeva Popova.
The presenter will be Professor Kraev instead of Ganeva Popova.
Hello, I'll try to be as quick as possible. So, the importance of osteoporosis and drugs for its treatment and fracture healing. So, let's say compromised bone quality and total healing environment leads to non-union fractures in osteoporotic bones, which presents a complex challenge in rheumatology and orthopedics. As the global population's age, incidence of osteoporotic fracture rises, which leads to increased delayed healing and non-union cases. The pathophysiology which underlies those type of fractures in osteoporotic patients involves impaired bone regeneration, reduced osteoblast function, and poor vascularity. Our traditional, let's say, strategies, which ranges from pharmacological interventions like biphosphonates and, of course, let's say, teriparatides, to surgical approaches such as bone grafting and mechanical fixation, often yields limited success due to the fact that the bone structure is weakened. Recent advances introduced novel therapies as growth factor stem cells applications, gene therapy, of course, and bioactive scaffolds, which offer more targeted and biologically driven solutions. Three-dimensional printing, nanotechnology further contribute to these strategies and holds promise for improved outcomes. Diagnostic approaches have also evolved, and we now integrate radiological assessments, biomarkers to identify patients at risk for those non-union fractures. Although we have those advancements, still challenges remain, which are high cost, some, let's say, complexities of the technique itself, and need for more robust clinical evidence. Future directions involve optimizing those innovative treatments, which should, let's say, validate their effectiveness in more extensive clinical trials, which should integrate some, let's say, personalized medical approaches, which should cater the individual needs of our patients with osteoporosis. So overall, integrating those strategies alongside with our traditional practices represents a significant shift toward more effective and personalized management of non-union fractures in osteoporotic bones. Going back to the roots, what is osteoporosis? It is defined as low bone mass and microarchitectural deterioration of bone tissue, which leads to enhanced bone fragility and therefore increase in fracture risk. World Health Organization defines osteoporosis as bone density that falls below 2.5 standard deviations for young healthy adults of the same race and gender, which we refer as T-score of minus 2.5. Risk factors are both genetic, due to ethnicity, due to age of the patient. We have 4 major risk factors: age, low BMD, bone mineral density, gender, and family history. Other factors include sedentary lifestyle, low body weight, cigarette and excessive alcohol use, low calcium intake, estrogen deficiency, of course, immobility, worsen exposure, medical problems, some, let's say, medications as well. And here we include the drug-induced osteoporosis, which is very often seen in rheumatology due to the use of the glucocorticosteroids, which are the most common medications for osteoporosis. Epidemiologically, the incidence of the non-union fractures is notably higher in patients with osteoporosis due to the compromised bone quality, which leads to impaired healing. Studies estimate that 5 to 10% of all fractures result in non-union fractures, with osteoporotic fractures particularly prone due to diminished bone density, reduced osteoblastic activity, and poor supply of the vessels. Clinically, those fractures can contribute to prolonged disability, increased mobility, higher burden on healthcare resources. The delayed healing process necessitates more aggressive interventions such as bone grafting, advanced fixation techniques, bone stimulators, which are further let's say, complicating our management. We should address those fractures in osteoporotic bones. Thus, it is critical in improving patient outcomes, and we should try to reduce, of course, the long-term complications. Pathophysiology of those type of fractures is multifactorial. It involves biological, mechanical, systemic factors which disrupt the normal bone healing process. Typically, it needs to go through well-coordinated inflammation, then repair, and then remodeling sequence. In non-union fractures, this sequence is interrupted. Let's say critical factor is inadequate biological response at the fracture site, which is due to impaired vascularity, poor osteogenic activity, insufficient recruitment of osteoprogenitor cells. Additionally, mechanical instability at the fracture site can also lead to excessive micromovement, which prevents formation of stable callus, therefore promoting fibrous tissue instead of bone. Systemic factors such as malnutrition, smoking, comorbidities as diabetes further compromises the healing environment because they affect the cellular function and the local inflammatory response. As a result, the fracture remains unhealed, which leads to persistence of pain, disability, need for more complex interventions. We should try to improve our investigation and diagnostic considerations for those type of fractures. So we should try to involve comprehensive evaluation which combines clinical, radiological, and sometimes biomechanical assessments. Clinically, persistent pain, abnormal mobility at the fracture site, failure to bear weight after the expected healing period are crucial indicators of non-union fractures. Radiologically, X-rays remain, of course, the initial tool, which reveal gaps at the fracture site. It may reveal also sclerosis or lack of callus. Advanced techniques also can be included as CT scan and MRI. Bone turnover markers can also be profitable here. Sometimes they are performed to evaluate the underlying osteoporotic activity and guide our treatment strategies. Accurate and timely diagnosis is crucial for effective management plan, including addressing the mechanical and biological aspects of healing in osteoporotic patients. So here are the key indicators: persistent pain, abnormal mobility, and absence of healing signs. Management of fracture in those type of non-union fractures requires multifaceted approach which addresses the impaired bone healing and the compromised bone quality characteristic of osteoporosis. Management typically involves improving bone biology, stabilizing the fracture, enhancing the healing environment. For pharmacological interventions as bisphosphonates, teriparatids, denosumab, which is a biologic drug, are often employed to improve bone density and strength, directly targeting the underlying osteoporosis. Pharmacotherapy, we have two FDA-approved indications for osteoporosis medication. First is, of course, prevention, and then treatment. We have anti-resorptive therapy, which prevents remodeling. We have bone formation therapy, which improves bone formation, and new procedures are including vertebroplasty and kyphoplasty. Generally, the treatment is divided into anti-resorptive therapy, calcium, vitamin D, selective estrogen, let's say modulators, biphosphonates, calcitonin, which target to inhibit the osteoclast function, while bone formation therapy includes, let's say, teriparatide, strontium, growth hormones, and factors which tend to improve bone formation. Management is surgical management of fracture in those bones remains the cornerstone for most cases of non-union fractures, with options including revision fixation using walking plates or intermedullary nails and bone grafting to provide osteogenic, osteoinductive, and osteoconductive support. Bone grafts, allografts, and bone substitutes like the mineralized bone matrix or calcium phosphate can also be utilized in those scenarios. Adjunctive therapy as low-intensity pulsed ultrasound and extracorporeal shockwave therapy can also be considered. Systemic factors like nutrition, vitamin D levels, and comorbidities is also crucial for optimizing the outcomes. Tailored patient-specific approach integrates those strategies is essential for successful management. Innovative approaches include are focused in enhancing bone regeneration, improving mechanical stabilities, and addressing biological deficiencies in osteoporotic bone. One of the options is biologic therapy, which include growth factors as morphogenic proteins, BMPs, such as BMP2, BMP7, which are showing potential in stimulation of the bone formation. They enhance the osteoblastic activity and are incorporated into surgical management strategies for those type of fractures. Stem cell therapies, of course, are included here, and also advancement in biomaterial science led to development of bioactive scaffolds and synthetic bone grafts. Nanotechnology is also explored with nanoparticles engineered to deliver osteoinductive agents directly to the fracture site. Also, we have enhanced implants which are explicitly designed for osteoporotic bones and implant fixation techniques. These innovation offer new possibilities for management of those fracture. Although still evolving, these approaches promise to transform non-union management in osteoporotic patients, which would improve the healing times, improve the outcomes where traditional methods are still insufficient. Here is the table with the traditional and innovative treatments and advancement and their advantages and challenges. As we can see, the advantages is faster healing period, customized treatment options for precision medicine, but let's say disadvantages include high cost and technical difficulties. Here are the different types of the new, let's say, therapies and their potential applications and mechanism of action. The future direction in management of non-union fractures is actually in osteoporotic bone centers that integrate advanced biologics, personalized medicine, regenerative technologies. We should incorporate those new, let's say, therapies, and we should strive to add new innovations in biomaterials such as bioactive scaffolds, nanotechnologies that aim to improve mechanical stability and localized delivery of therapeutic agents. 3D printing technology also creates such, let's say, implants that offer better fit and integration. Overall, evolving landscape of therapeutic innovations offer hope for more reliable and patient-specific management. Those are the reference used. Thank you for the attention.
Thanks to Dr. Kerr for the interesting and detailed presentation. The next topic is torn ligaments and knee injuries from vehicle accidents, medical legal aspects. The presenter is Professor Timonov.
Good morning, colleagues. My specialty is forensic medicine away from surgical traumatology, but I just try to present a case, a topic which is the mixture between the traumatology and forensic medicine. Torn ligaments and injuries in the car to pedestrian accidents, medical legal aspects. I chose this topic first of all because you'll see the importance of the traumatologic knowledge in the forensic practice to reconstruct the crime. And secondly, 3 months ago I got the same damage and my surgical treatment was done by Dr. Stefanov. Short advertisement about him. In the forensic practice, the gold standard for these cases, similar cases, this is the bumper fracture. The bumper fracture was introduced, was described by orthopedic specialists 70 years ago. This is the synonym of the tibial condyle fracture. But then, based on the change in the architecture of the car, the bumper fracture means the fracture of the shin bones, diaphysis, especially with the triangular fragments. Nowadays, the modern cars have bumpers which are widened, incorporated in the car's front. Based on these changes, you can see the difference compared the difference damages compared to the classic gold standard bumper fracture. The aim, the goal of this present case is to show, first of all, the usefulness of the knee joint examination, the forensic practice, to reconstruct the crime, to identify the position of the body according to the car, to prove the upright position of the body, and so on, so on. And secondly, help orthopedic traumatologists to identify the damages to knee joints in the similar cases. Now, on this picture, you can see the general mechanisms causing the damage to the anterior cruciate ligament or to the posterior cruciate ligaments, depending on the site of applied traumatic force. Now, this is the real case. From my practice, you see the victim found on the road, but unfortunately, the car wasn't identified. This is the weak spot in the forensic practice, because based only on the distributions of the trauma damages, the position, the distributions of the injuries, forensic pathologists must identify, must reconstruct the whole crime, plus forensic pathologists must identify the car, of course. Now, here you can see the autopsy finding. During the autopsy, forensic pathologist found the damage to the left knee joint, accumulation of the blood into the joint capsule, damage, partial rupture of the anterior cruciate ligament, bruises of this ligament too. Compared to the right knee joint, the right knee joint was intact without any damages. Here you can see, you have seen very interesting autopsy finding. During the sagittal section of the tibia, forensic pathologist found a hemorrhage bleeding into the epiphysis and metaphysis of the bone. From the forensic point of view, this damage is caused by the sudden dislocation between the tibia and the femora due to the primary impact. From the medical point of view, it's very important because this bruise, this hematoma, deep hematoma, is the perfect site for the bacterial growth, resulting in the osteomyelitis. Now, to sum up this case, you have seen that nowadays the bumper fracture is absent when forensic pathologists examined the victim, the pedestrian victim, due to the modern cars. But at the same time, the examination of the knee joint is very important to identify the position of the body according to the car. And on the other side, based on this injury, forensic pathologists must identify the type of the car when the car wasn't identified. Thank you for your attendance.
Thank you. So the last presentation, ask Simoncini, back to Newton, hip and knee biomechanics.
Good morning. Thank you very much, Professor Rosa, Professor Macauro, for the invitation. and thank you to the board. The doubt is the base of scientific activity. Doubting is what makes science what it is. But at the same time, we cannot doubt anything. There are things that we are not allowed, let's say like that, to doubt about anymore. One of these is, of course, Newton mechanics. And so what I would like to do today is to give you a few certainties in your activity, in your scientific activity. The problem is that if you consider the human body as a scientific mock-up, experimental mock-up, it is very difficult to separate the effects. You cannot say, okay, let's take into account this effect and this, and no. Everything comes together. So when you want to understand what a specific effect does, it is not so easy. But there are things we can count about always. So I would like to, of course, what I can give today is just a gaze through the keyhole on biomechanics. It's then up to you, to your curiosity and need during your career to go in depth on it. So let's start from simple stuff. The question is, can an apple, the famous Newton apple, fall upwards? That's obvious. No, it can't. Even if I try 1,000 times, I take this apple and I throw it, let it fall 1,000 times. Of course, yes. For 1,000 times, this apple will fall downwards. But wait, sometimes strange things happen. Because of what? Because of confounding factors. So what does this image, why this man is floating upon you? Try to guess. Why? The wind. Or it's jumping. Or what? The image is a fake. It could be just a fake, you know. Or there are cords keeping it, holding it in some way. Yeah, but if you ask 100 people, no one is going to ever tell you, well, gravity is not working anymore. There is no way. Okay, so this is the first thing that you can count about, the gravity, the forces. And let's give the speech to one that's a true expert about forces. What he says an important thing, that the forces is our ally, because we know about it, we can count on that. And not neglect it as it wants to be. Because the joints of the human body are all about forces. So what Mr. Newton would ask you? We are mainly talking about arthroplasty here. So the question is, the basic question is what you really do when you make an arthroplasty. What you really do. What Mr. Newton, Isaac Newton, would like to hear from you when he asks you this question. What you really do when you make an arthroplasty. We are talking about forces. guess. Anyone? We're talking about forces. So what you really do is you create a new balance of forces because you are working on all the biomechanical parameters that affect the forces that affects the joints. Because you establish a new set of biomechanical parameters, a new set, length, stretching, etc. You know that forces, they move our joints. Of course, it's all about forces. Okay, we also can see after that which kind of forces. But wait, they can wear it out too. It's not just about moving. Any movement creates wear. They stabilize the joints. Of course, muscles and the gravity itself, they stabilize the joint, but can make it unstable too. So you see, the balance is the word you have to look after. Because you have an important effects, which I call the chain of wear. You have forces. Forces that create loads. Loads that create stresses. And you see, you can finish this figure by your own, because of course stress creates wear. But that's life. You cannot avoid it. Anytime I express a force, I make a movement, I wear something. I'm wearing my shoes. I am wearing the floor. I am wearing my hips. But we also have another effect. What happens is when forces are unbalanced, when you create peak loads, that is maybe the surfaces are not as wide as they should be. You create concentrated stresses. Concentrated stresses, they generate accelerated wear or instability. When you unbalance forces, you create instabilities, limping, stiffness, or whatever. This is not life. This is a mistake. And be careful, because wear can affect both materials and soft tissues. Soft tissues undergoing for a long time unbalanced forces, it wears out and fades. Actually, why the joint arthroplasty, not just hip, they fail? Which of this ranking could be related to unbalanced forces? Of course, it goes without saying the wear of the acetabulum insert, but also the implant breakage, of course. And I didn't include the breakage, of course, of the carp, but it is, because if you break the liner, then you break the carp, and you create metallosis and whatever. But wait, loosening could also come from wear of polyethylene, because the polyethylene, the debris of polyethylenes, they create inflammation, etc., etc. You have the loosening of the carp, for instance, or the stem. Also, instability, because of course when you when you wear, for instance, the liner, you create instability. So actually, more than 30% of the possible causes of failure for an implant comes from an imbalance of forces, could come. So let's see what kind of forces we may have, we actually have, in a joint. We have passive forces, such as gravity, and ligament tension. And we have active forces generated by muscles. So the point is what I call the tau of total joint arthroplasty, which is the equilibrium of passive forces respect of soft tissues to allow a well-balanced deployment of active forces. So to avoid peak loads, reduce stresses, minimize the wear of polyethylene when it's polyethylene and soft tissues. And why not stabilize the joint? The image is of a knee, because the knee, of course, is a very sensitive part of the body when forces and balance of forces are taken into account. So we have two tools during surgery. You have, because I am an engineer, so it's not up to me. But you have cut alignment and balancing of the ligaments. This is true for hip, this is true for knee, shoulder, etc. When we go to the hip, of course, there are certain similarities between, for instance, shoulder and the hip, but there is one important difference, is that the shoulder is an intrinsically unstable joint, while the hip is intrinsically stable. What does it mean? Is that any movement brings to stability or instability. The hip comes in place by itself, the shoulder won't. So, as an engineer, as I saw this picture for the first time, I said, this reminds me something as an engineer. What could be? What this reminds you, this figure? Of course, this is a hip, a section of the hip. But what an engineer could think when he sees that? What he could think about? Sorry? A bridge. Something like that. A bridge is made of arches. This actually is an arch. Also with a keystone. You see the keystone, which stabilizes the whole structure. So you also have, of course, a center, a barycenter of the structure. And when you stand in upright position, you have an even distribution of force. I need an assistant. Volunteer, you. Come. You are volunteer, correct? So, you are walking. Okay, we are now analyzing the guide. What happens to the muscle, to the body, etc. So you're walking, and until you have both feet on the ground, you are in a more or less balanced position. Okay, so let's analyze what happens when you raise your leg. Okay, And what we do, you are walking, you raise your leg, and suddenly all of your hip muscle fail. All of them. So try to analyze what your body does in that moment, where it goes, how it's, okay? Yeah, you have this temporary instability while you go there. So take into account that you have a dynamic situation, but also static forces in action. So try to analyze movement by movement, effect by effect. What happens? You are like this, and suddenly all the muscles here fail. What your body does? How? Where? In which direction? Of course, you tend, but wait, exactly in the direction. In some parts, yes, but also you are hinged by the friction to the floor. So you also does a different one. So you go like this, but you also go like this, correct? You tend to turn around the hinge of the hip. So if you, at a certain point, your muscles come back. So which is the action of the muscle? So you tend to flex the knee, you tend to flex the hip, you tend to turn, you tend to fall like this also. So what are the muscles that come into action to keep your balance and go on? Of course, so rectus femoris for the knee, gluteus maximus for the hip, just one of them, because of course there are several. Abductors to keep you not falling in this direction. Extra rotators, because of course when you do like this, you intra-rotate, okay, and to balance, you extra rotators, they have to come in action. So you see, what looks like a simple strolling actually activates a lot of muscles, balance and counterbalance. Okay, thank you for the collaboration. So, abductors, biceps femoris, rectus femoris, gluteus maximus, etc. When you go back in bipodal position, the things relax a little bit. This is to say what? That muscles also increase the forces on the joint. You see very high values. And this is why it's important. You can imagine when these values are even unbalanced, what kind of peaks they could reach. When you go down, you find the knee. My presentation is not specifically about the knee, but I think this deserves consideration. You have the body weight applied on the hip, of course. And you have a reaction from the floor. The point is, the line WR is called the mechanical axis. They have to run through the center of the knee. If it runs to the center of the knee and the contact surfaces are 90 degrees with the mechanical axis, then you have pure compressive forces that are the only ones that are those that can ensure the maximum stability and the minimum wear of the knee. Because when you unbalance it, the first thing that happens is that one one plate of the tibia is not charged, and everything charges on the other one, just for instance. And we see, it's not our goal here, but we see that there are important consequences on that. So pure compressive forces are the word, is the word. And you see that's also for the knee, the loads are very important. So we have a bunch of biomechanical parameters, and then I close the presentation. You have in the hip, the first parameter is the offset, is the lever arm of the force exerted by the abductor muscles. You ever wonder why the muscles in the body, in the skeleton, are attached, almost in all cases, to bulges, to extensions of the bones? That's because they give the muscle lever arms. So when the muscle attach to the bone, if they attach on flat, you have a smaller lever arm. If they attach on a bulge, such as the trochanter, for instance, just for instance, they have a higher lever arm, so they can act more efficiently. Of course, the bulge cannot be like this, but of course there is a balance. And the offset is 1. The longer the arm, the smaller the force, etc. We have said that. The vertical drop, this one, of course, accounts for more or less the same thing, but also for the leg length. And a difference in the leg length is one of the most important unbalancing factors for limping, for forces, etc. The CCD angle is another important factor that affects both offsets and vertical drop. I'm sorry, I have to go pretty fast here. The center of rotation also affects all the parameters. And the center of rotation during surgery is affected by the gesture of the surgeons when you rim, more or less. So even rimming can affect the biomechanical parameters. The effects of differences of unbalancing can be different. So here I'm not going through this, you can just read it, but of course it can be important. So all this speech comes to this slide. What actually means having an unbalanced forces on joints. You can go through this maybe even much better than me and understand what it means. Other factors, but I have to cut. And just one word about the possible implants. I am a fan of modularity in the implants, but not as a solution for everything, because they run their own risks, but as a solution in particular cases. Most part of the time, some monoblock is the best choice. But sometimes modular implant can allow you to overcome specific problems during the surgery. So that's all. Balance is everything. Thank you very much.
Thank you, Dr. Simoncini. So we'll finish this morning's session 30 minutes after the schedule. Before to proceed further with the coffee break, we'll do a photo for the course in front of the auditorium. So let's go down, and after that you'll have coffee break, about 20 minutes, and we'll continue with the second part of the morning session. The second session will start at 11:45.
activating the function of lost muscles and creating motion in the prosthesis. Let's take a closer look at what's inside the power knee and how it works. At the heart of the power knee is a DC motor with a harmonic drive transmission. Ensures the knee always knows when it's in contact with the ground and needs to stay locked. The knee also reads whether the user is trying to bend or straighten their leg, as well as the speed and direction.
Are then translated into what you machinery and transition between the different parts of your arm. It's picking up those muscle signals.
Eine Orthese nicht machen könnte oder eine Polio festgestellt.
The first.
Yes. I will announce this.
Yeah, start right now. Okay.
You, the next. Dear colleagues, we continue with the second part of the morning session. And the next topic is custom-made individual 3D printed endoprosthesis for tumors of the lower extremities. Presenter is Professor Stavre.
So, yesterday the text was in English, but you are in Bulgaria, so today the text will be in Bulgarian language, very difficult language, and I will speak in English. So, yeah. You are coming for 13 years, so you have to learn a little bit Bulgarian. No? So, yesterday's case was about 11-year-old girl. Today's case is about 4-year-old boy with tumor, again Ewing sarcoma. But yesterday it was upper extremity, today it is lower extremity, so today's prosthesis is a growing prosthesis, because if the prosthesis is not growing, there will be leg discrepancy. Nowadays, this is the introduction, the basic application of the 3D printing is the manufacturing of anatomic models and for planning and simulation of surgery, patient-specific instrument, patient-specific implants. So today's case is a 4-year-old boy, so there are no manufactured serially prostheses for 4-year-old boys. So we had to do a 3D modeling, then prepare a special prosthesis for this young boy. Otherwise, we had to amputate his lower extremity. The basic application is 3D printing for preoperative planning and for teaching in the oncologic orthopedics. The second, this is for individual resection blocks prepared through 3D printing. This is very widely used. So we can order 3D blocks and they come together with the prosthesis, so only we put the blocks, we do the resections and implant the prosthesis. Third, which we use, this is 3D printed models for individual endoprosthesis. This is in our case. In most children today with bone sarcomas, nowadays in the 21st centuries, are offered limb sparing procedures, preserving the extremity. When treating children below 12 years of age, the result is substantial leg length discrepancy. One of the solutions is the implementation of a growing endoprosthesis. The bone sarcomas are rare malignant tumors which are affecting mainly young children between 5 and 25 years of age. In the past, the only possibility was the total amputation. The life longevity has been from 0 to 15%. So in the past, only 15% of the children survived, and most of the patients died. They died with their extremities being amputated. The cause for that usually were lung metastasis in 95% of the cases, when the primary diagnosis was a sarcoma. In the last 30 years, we became witnesses to substantial growth in different disciplines, and this led to the modern concept for limb-sparing surgery. And this limb-sparing surgery is possible mainly due to the effective systematic chemotherapy. So we work with close conjunction with the pediatric oncologists. Today, 85% of the procedures with bone sarcomas is a limb salvage surgery, and only 15% are amputations. And the life longevity, the children who survive more than 5 years are around 60%. So if one patient survives more than 5 years, this is considered to be an excellent result. The limb sparing surgery in small children is rare, and it is difficult to be performed because of the bone growth, which is not only in length but also in radius. For example, the resection of the distal femur in children below 10 years of age leads to loss of 1.6 centimeters of length every year. So if we implant a prosthesis to the distal femur, every year the affected extremity will become with 1.6 centimeters shorter than the other one. There are several surgical approaches to deal with the length discrepancy. The first is amputation and rehabilitation with external prosthetic replacement, external prosthesis. The second procedure is rotational plasty, but this is applicable only for tumors in the distal part of the femur. The third, this is osteoarticular allograft, which is not possible for growing, so this is not a good solution. The fourth option, this is combination of standard non-growing endoprosthesis with epiphysiodesis of the opposite extremities. So we block the growth plate of the opposite extremity so that there won't be any leg discrepancy. There are also described techniques for arthrodesis using combination between allograft and autotransplants, vascularized or not vascularized, followed by conventional lengthening technique described by Professor Ilizarov. But this is not modern technique. Each one of these decisions is not quite good. The optimal surgical solution is different for every age group. The limb sparing surgery is almost impossible for children below 5 years of age. In our case, the child was 4 years old. And the endoprosthetic replacement with tumor endoprosthesis is more prescribed for children in the age group between 5 and 14 years. By the end of the 70s, we started to use a growing endoprosthesis with different mechanism for growing, for lengthening. The growing endoprosthesis usually have two basic parts, stem and articulation, and the growing part is usually positioned at the region of the stem. So the first generation is seen here of growing endoprosthesis. So we see that when the child grows, we have to do a big approach, expose the part, and gradually we implant these tubes which are gradually being with increased length. but for every separate procedure, we have to cut open and implant these small tubes in order to make the stem longer. So the second generation Моля го пусна това видео. Не. Цъкни отгоре. The second generation, this is actually our prosthesis, is using an expansion mechanism like a car antenna. When we rotate bolts on the femoral and on the tibial parts, we can elongate the stem like a car antenna. The third generation of growing endoprosthesis are using magnetically controlled mechanism, but the problem is that when using this type of prosthesis, we can elongate with maximum 3 to 4 centimeters. In our case, we needed a greater extent of elongation. That's why we decided not to use a magnetically controlled elongation prosthesis. So this is our case. On the left side, you can see quite a big Ewing sarcoma. This is the AP view, this is the lateral view. Ай пак да пусти видеото, че няма как се пуска. And this is the boy. When he came Okay, leave it. So this is the appearance of the tumor when the boy came to our department. And this is the project for the prosthesis. This is the 3D model of the tumor. And this is the primary model with the plant resection. So we plant to excise 3/4 of the tibia, and to replace these 3/4 of the tibia with a growing prosthesis. It grows from here. And we were planning to do mechanical fixation to the distal part of the tibia with interlocking bolts, with interlocking screws. So we didn't like the primary model because we had to cut the distal femur, and the distal end plate of the femur is responsible for around 75% of the growth of the femur. So when doing so, we stop the growth of the femur, and we can only elongate the tibia. So we proposed a new model of the prosthesis. So this was the primary in yellow, and the new, we plant higher resection of the femur with a growing component of the femoral part also. So this is the actual model. Finally, the prosthesis was covered with the so-called Lars tube for better fixation of the muscles to the prosthesis, textile tube. And this is some real-time view. This is the distal fixation. As you see, the distal growth plate of the tibia was preserved. So the tibia will grow distally, but proximally we have to use the elongation mechanism of the prosthesis. Може пак да го пустите. So this is the exposure of the distal femur right before resection. We invited a vascular surgeon because if we injure the vessels, it is game over. So you can see the distal femur right before resection of the distal femur. The tibia, the 3/4 of the tibia has been already resected. So this is the prosthesis already implanted. Ligamentum patellae proprium was reinserted to the prosthesis. There were holes. And this is the textile tube which was put, and then the ligamentum patelli proprium was reinserted to the prosthesis in order to enable the extension of the knee joint. And this is how it looks like. This is the AP view and the lateral view. This is the part from where the femur grows, and this is the part from where the tibia grows. That's why it is a double growing prosthesis, able to grow from the tibia and able to grow from the femoral part. So this is how it looks like on the table. This is the growing mechanism of the femur, and this is the growing mechanism of the tibia. So this is 6 months after surgery. As you see, no hair because of the chemotherapy. When they do the chemo, може ли другото? So 6 months after surgery, walking with aids, we left the operated extremity a little bit longer to save one elongation to the child. And this is 8 months after surgery, walking alone. Пусни го. This is the last video that the parents, gypsies, sent to us. So the child comes from a small village near the Black Sea coast, and we are very proud that we managed to save the extremity. His father, this is the 5th child of this gypsy family, and the parents didn't allow any amputation because the father was with amputated extremity due to a car crash. So the mother said, my husband is with amputated leg, so I will not let you amputate the leg of my 5th boy. So this is the conclusion in Bulgarian language. Our purpose is, if possible, to do a total revision when the growth of this child finishes and exchange this growing prosthesis with a permanent one. If, of course, there are no metastases, this boy is expected to come to us next month for plant elongation of the prosthesis. Thank you.
Thank you, Professor, for your presentation. Now we go at the next presentation, artificial intelligence powered lower and upper limb assistive device, MONOV.
Okay, hello everybody. I'm Simeon Monov. I'm assistant professor in the Plovdiv University. I'm in a different field in informatics and mathematics. Come from the Faculty of Mathematics and Informatics, but I concentrate on artificial intelligence, machine learning algorithms, and similar sciences. Now, today I will talk, just give you an overview lecture about examples and some case studies and how AI is being used in orthopedic assistive devices. Unfortunately, sometimes we have to do amputations and things like this, but what's next for these people? And AI has been really helping a lot recent years, especially with the huge development in this sector of the science, helping and trying to craft a new future of these devices and revolutionizing their design and functionalities. Now, main roles of AI in how it helps make these devices better is different AI algorithms. One of the most important is they create and they learn unique patients' patterns, movement patterns that they do, and this way they adapt the device functionality to to the person and personalize it. They use real-time data. They can change functionality real-time on the go if environment changes, and they adapt very fast and adapt the functions of the device itself. Also, they're being used for rehabilitation purposes. There are certain systems created with AI that help faster recovery times and more comfort for the patients. Now, in lower limb orthopedic devices, here I will go in certain examples. These are some case studies and some popular such devices. How AI works, for example, for lower limb orthopedic devices, assistant devices, they predict movements. They can predict, AI itself can predict what the patient wants to do and how to move, and learn, in fact, from the patient and make some kind of a personalized profile, and this way they control the device itself to have very adaptive response to a variety of terrains. It helps climbing stairs, running, walking on uneven surfaces, and makes the things more natural for the patient. Now, here a very prominent case study is the Ulcer's Power Knee. Ulcer is a company that has a lot of innovative prosthetic devices. They've created the Power Knee in 2006. This is the first motor-powered knee, and it's been developed throughout the years. New versions come. Their recent version uses relies a lot of AI algorithms and machine learning algorithms, which kind of they learn what the patient wants to do, how they want to walk, and what is the surface they are walking on. And by using some motor systems, they help the patient to walk more naturally and gives them a lot of good experience. And of course, the outcomes and the feedback from these devices are very positive. Yes, they are on the expensive side. These devices are not cheap. But hopefully when things become more and more popular, their price will go down as well. At the end, I will try to show you their websites. I mean, I have a few other examples, and maybe you can see how in reality these things work with some quick videos. Now, about the upper limb assistive devices, similar to the lower limb, these devices, they adapt, but very important, in fact, they kind of detect what the user wants to do or the patient wants to do to achieve, how to use them, and they learn these things, and then they can help the patient to adapt, to learn very fast to use them. One case study here is the Co-op's complete control system. This system is a bionic system that uses pattern recognition. In fact, it uses the myoelectric pattern recognitions of the signals from the muscles. And they can very easily, I mean, users say that it's very easy to start using these hands. In this case, is shown upper limb prosthetic, which is a hand. And these are real pictures, real people. Same with the previous picture. And kind of detects these patterns, what you want to do, and the hand works, and it's quite, people, I mean, I've watched many videos, and people really say very positive things about this. Again, I will try to show you a video if time allows at the end. Now, another area is the AI-driven adaptive orthotics. These devices are used for people who are not really for real prosthetic use, and they help them walk better, for example. They use, again, algorithms, these machine learning algorithms, very adaptive. In real time, they can detect the surface, what you want to do, or they can detect you want to run, then they control the device in a run mode. And an example here is the Autobox C brace. This is the first, the world's first entirely computer-controlled leg brace. that very automatically adjust for different walking speeds and terrains, and really helps the people to improve their mobility without needed of artificial or prosthetics. Now, I mentioned also the rehabilitation, how AI is used in rehabilitation, especially home rehabilitation. There is many AI, not many, but there are AI systems that they track your progress. They can adapt exercises in real time, depending how your progress goes. It's not like a fixed rehabilitation program, but it can adapt to the patient's progress. And they can provide guidelines, motivate the people to continue with their program. An example here is the Neuro Rehab VR system. Here you can see a picture how it looks. It's a virtual reality system that gives you certain scenes, try to simulate the real world scenarios and make you do certain exercises and make the things more flawless for the patient, and recovery times are much faster, and of course healthcare needs are much less in this case. You can do all this at home, and that's what it is designed for. Benefits, we talk, to summarize, what are the benefits? Yes, these devices, they enable patients to perform daily tasks with confidence. They help them do things that they cannot do without these devices, or they help them do more things than the traditional non-AI powered or just static prosthesis. It reduces the healthcare costs by reducing the long-term care needs, especially in rehabilitation. And they create these personalized rehabilitation paths they can, as I showed you on the previous slide, they help people and they adapt to the needs of they check the progress of the rehabilitation itself, and it can be faster for many of the patients. Of course, there is many challenges. I've listed a little bit here, just few. One is, as we understand here, we talk a lot of very personal data. I mean, this is, these AI algorithms, they save and process this data, and this is very, very personal data that they manage. And yes, it's a problem. We need to be sure that this data is protected and not protected from breaches, because it's really personal data. Another issue is compliance with the current healthcare standard. It's, this is a totally new thing, and many things have to work out and change here. And last but not least is the overcoming the resistance to new technologies. I know many people, it's hard to accept all these new things, but life is like this, and in every other field, we have to accept AI, and I believe personally it helps a lot, can help us a lot. And what is the future? The future is, many things can happen, and very important is the intersection of AI and robotics, and how they work together. The working there together can give us really unprecedented orthopedic solutions. Also, AI can be utilized for predicting complications, for personalizing even interventions to the patient by predicting and understanding what the patient needs. And of course, the multidisciplinary collaboration is very important in this case, to work together to create really future innovations. And in conclusion, I would say that AI is really revolutionizing the patient care, and it's creating very personalized and adaptive solutions for the patient, very individual. And there is a vast potential of continuing and working and implementing AI in many new fields. Now, I will quickly just show you these case studies I showed. This is the website. This is the Power Knee I was talking about. This Power Knee has been on the market for a while, but it's been developed a lot, especially recently. They have a small video just showing how it works.
Power Knee is the world's
it's-
first actively powered prosthetic knee joint. It provides unique benefits not found in passive microprocessor knees by replicating the function of lost muscles and creating motion in the prosthesis. Let's take a closer look at what's inside the Power Knee
This is,
and how it
I
works.
will move it.
At the
not
heart
to
of the
lose
Power
much time,
Knee
but,
is a DC
yeah,
motor
it uses
with a harmonic
very,
drive transmission. It is designed
unique
to
motor
deliver
system
high torque and reliable performance.
and AI algorithms
The
to
motor generates powered lift to help its user out
control
of a
it.
chair or up a set of stairs. People with limb difference expend 30 to 60% more energy than those with intact limbs and have reduced walking symmetry that is associated with a greater risk of low back pain and osteoarthritis. Powered swing helps by improving symmetry and reducing the energy needed to control. Power Knee features an energy-returning stance flexion control, which provides
you can
shock
see, yes,
absorption
this is
and more
graphics.
closely
There is many
imitates
videos you can
and
see on
needs to
YouTube.
stay locked.
Find
The knee
out
also
more, not
reads
only
whether the
about
user
this
is
knee,
trying to
but there
bend
is other
or
products on the
straighten their
market. I
leg,
just
as well as
chose
the
it as
speed and direction
one
of
of the first
movement.
pioneers in
Combining
this
this
field.
information with state-of-the-art algorithms for decision-making provides the right action at the right time. With 25 hours of battery power, the data...
So, yeah, here you can see there's pictures of real people using the device. And the other one was, I was talking about the upper limb. You can see here on this picture how they learn, how they teach the system. They use special sensors, and person can learn, and I mean, they use some software that is AI enabled, and people can learn how to control the hand. It's a unique system. I can show some examples. I mean, there is a small video here talking about people using it. There is a few people.
The COAP system is picking up those muscle signals. The muscle signals are then translated into what you perceive as opening or closing your hand. Before, it felt like I had 3 different types of machinery I had to operate. I had an elbow, I had a wrist, and I had a hand to operate. Now it's become one unit that works together in unison without having to think about the transition between the different parts of your arm.
So from my understanding, it's more like just the makeup of the pattern of muscles you use for each different grip and differentiating that pattern of muscles.
With a COAP, there's sensors all around because each one has a different pattern to it.
Are you ever worried about like making it too light and then accidentally triggering something when you go to do something else?
Unintended movement is what we would call that. That's limited, it's decreased a lot because each motor has a movement pattern to it and it won't move until you get that one.
The fact that you can just hit the button.
Okay, yeah, again, let's not save time, but I hope you guys got a visual idea how these things, how it works. And these guys I will not show video. This is the Autobox C-brace. The brace that can help people achieve things that they couldn't do without it. I don't know, maybe I can zoom some of these pictures only. But we can see some examples, real examples, how the brace used by people that couldn't do this without it. And helps them, of course, improve their life, even dancing. And so on. But yeah, that was my presentation. Yeah, I believe there is a bright future here. I know there is a lot of resistance, but I guess we have to adapt and we have to accept the future. Thank you, guys.
Thank you, Dr. Malo, for this very interesting presentation. And the next topic is hip and knee surgical approaches. The presenter is Professor Fenger. I'm giving the floor to Fenger.
Good morning to everyone, and thank you to the organizers of this course for the kind invitation. So today I'm going to show you the hip and knee approaches, but due to time reasons, only 10 minutes, unfortunately, I will try to expose the most used ones. But obviously in the theater, we can perform the approach you prefer. I will also show you some videos made during my experience at the Rizzoli Hospital, Sicily, and Bologna. The anterior approach to the hip is gaining increasing popularity, especially in prosthetic surgery. But its use has been described also for flexor release and drain infection in children. Its advantages are in the presence of an intermuscular and internervous plane, but disadvantages are a limited exposure. Good attention must be paid to lateral femoral cutaneous nerve, femoral nerve, and femoral artery. The patient is placed supine on the operating table. You can use a traction table or not. With a bed, usually you can economize an operator. The field must include iliac crest and pubic symphysis proximally, anterior surface of the thigh distally. The skin incision begins 2 fingers below the anterior superior iliac spine and extends distally for approximately 8 centimeters. In a linear fashion, imagine between the tensor fasciolata and sartorius. This interval can be identified by palpation. Subcutaneous tissue is reflected to the level of the fascia. Sartorius and tensor fasciolata muscles are identified, and the fascia investing these 2 muscles is split longitudinally. The splitting of the anterior fibers of the tensor muscle helps to protect against injury to the lateral femoral cutaneous nerve, as you can see in the video. Then tensor is separated from the sartorius by a sharp and blunt dissection, and the sartorius is reflected medially and the tensor laterally. Further exposure is straightforward, and it's usually done by palpating the femoral head and exposing the capsule by blunt dissection. The ascending branch of the lateral circumflex artery and vein do cross the field, and so they must be ligated or cauterized. Then you reach the hip joint. In this level, the gluteus medius and tensor fasciolata are further reflected laterally, and the attachment of the reflected head of the rectus femoris is observed, and must be incised. After that, you can open the hip joint by excising the anterior capsule, and dislocation occurs with extension and external rotation. The posterolateral approach is the approach I prefer and perform daily in clinical practice, always for the hip prosthesis, but it can be used indeed for piriformis release or great trochanter resection. It exploits an intermuscular plane and interneural nerve and gain an excellent access to the hip. Disadvantages are a risk of hip dislocation, of sciatic nerve damage, and the vascular supply damage. So the risks are sciatic nerve and proximally gluteal nerve. The patient is positioned in lateral decubitus with the specific pelvic supports. And the skin incision is typically centered over the trochanter, just posterior to the midline. The first time the incision is 12 to 14 centimeters, but you can perform it shorter maybe after a good experience. And maybe straight or follow the fibers of the gluteus maximus and then curves slightly posteriorly. Then the section exposes the iliotibial band and proximal gluteal maximus is divided along its fibers posteriorly. The iliotibial band is split with scissor. And the posterior portion of the gluteus maximus is retracted posteriorly. The anterior fiber of the gluteus maximus and tensor fascia latae are retracted anteriorly. Often we can use self-retaining retractors, like the Charlie retractor. After the positioning of the retractor, you can perform a trochanter bursectomy with the exposing of the extra rotator of the hip. You need to protect the gluteus medius with a curved retractor and short rotator exposed then. Distally, you usually can see the quadratus femoris and may or may not be released from the femur. Then you can see superior and inferior gemelli, obturator internus and externus are tagged with the two sutures usually and released more proximally. Then you can see piriformis tendon and detach from the styloid process of the trochanter. You can perform a suture and then you can retouch it. So the entire sleeve of short rotator are elevated from the capsule as it is related with the cutting cautery just at its insertion at the posterior margin of the trochanter. And the posterior capsule is entered as is excised as needed. The labrum is incised with internal rotation of the thigh, the femoral head dislocated posteriorly. Let's go to the knee. The anterior approach is the most performed to perform the total knee arthroplasty, but can be used also for distal fracture management and patellar surgery. Advantage is extensible and with a low risk of complication of wound, but disadvantages are obviously the limited exposure of the posterior aspect. Risk are damage of the intrapatellar branch of saphenous nerve. The patient is positioned supine in the cupitus with the lower limb on specific support. And usually an anterior midline incision is performed. After that, the extensor mechanism is exposed both proximally and distally. You need to develop a modern skin flap. And the arthrotomy is parallels the medial border of the patellar tendon, beginning at the insertion of the pes anterior tendons. The arthrotomy is then continued. Along the medial border of the patella, where most surgeons leave usually 1 centimeter sleeve of soft tissue attached to the patella in order to facilitate later closure. The quadriceps tendon is then divided for a distance of 8 centimeters above the superior pole of the patella, and the retropatellar fat is split. The patella can be everted and the knee can be flexed. But an everted patella puts the patellar tendon at risk for avulsion as the tendon is apt to peel from its attachment. So if excessive tension is noted to the tendon, the patella should just be subluxed and not everted. Or you can perform a quadriceps snip. During total knee arthroplasty, a subperiosteal release of the deep portion of the medial collateral ligament can be carried out, especially if you need to perform a prosthesis in a varus deformity, a severe varus deformity. And as the knee is progressive flexed, the tibia can be externally rotated, the anterior cruciate ligament can be excised. And the posterior medial corner of the tibia can be subluxed anterior to the femur. Then a retractor positioned around the tibial attachment of the posterior cruciate ligament can lever the tibia forward and improve visualization during detection of the proximal tibia. Last one, subvastus medialis. The incision is the standard subvastus, is the standard midline incision, but you need to take care to develop a medial skin flap to define the inferior border of the vastus medialis obliquus. You must note that the vastus medialis attaches to the patella at a 50 degrees angle and always extend more distally and more medially than the surgeon is usually inclined to think. The subvascular osteotomy is made by incising the retinaculum and joint capsule at the vastus medialis muscle edge proximal to distal at the same 50 degrees angles as the vastus itself. You need to take care to extend the arthrotomy to the mid-pole of the patella and not to cheat the arthrotomy up toward the superior pole of the patella. At the mid-pole, the arthrotomy is turned distally and parallel to the medial border of the patellar tendon. Then the fat pad is split and the patella can be subluxed into the lateral greater of the knee. In case where the patella is difficult to sublux laterally, the surgeon will usually find a fine band of tissue proximally medially, the medial patellar femoral ligament, that must be released. Once this ligament is released, the patella will sublux laterally with relatively little force. So I concluded. I prefer to show some videos so you can fix better in your mind what you can do later in the theater. Thank you.
Thank you. Thank you, Domenico, for your nice presentation. And now it's time for the last presentation, ankle foot surgical approaches. I ask Vitiello.
Good morning. So, this is the index of the approach that we are looking. So the first of all is the direct anterior approach to the ankle. This is the most useful approach for the ankle arthroplasty. There is a straight line between the malleolus, go to the crest of the tibia and go down on the foot on the second metatarsal axis. This is the most useful approach to see all the distal tibia. In the deeper layer, we are to take care of some different nervus. The first of all, in the lateral part, is the superficial peroneus nerve, but the other is the neurovascular bundle, taking your mind that there is a big variability in where is the neurovascular bundle to the ankle. Mostly is behind the flexor hallucis longus, extensor hallucis longus, but you can see also behind the extensor digitorus communis. So take care of it, and in the deeper layer we have to go between the extensor hallucis and the extensor digitorum. And as you can see here, there is the capsule. And this is the visualization of the approach. So we can see all the ankle joints, in particular also the medial part of the malleolus. So this is very important in the ankle arthroplasty, and if you extended the approach on the foot, we can also see the fibula. That is, with just one approach, you can also manage the ligament of the lateral ankle during the arthroplasty. So the other is the anteromedial approach. So we start on the crest of the tibia and go down following the anterior tibialis tendon. This is the most useful approach when you have a fracture with a comminution on the medial side or a fracture of the medial malleolus. And you have to take care of the anterior tibialis tendon sheath, taking in your mind that a damage of the sheath is correlated with a surgical site infection after the surgery. So we have to preserve as much as we can the tendon sheath. As you can see in the distal approach, we can see distal part of the tibia and the medial malleolus. The other approach is the anterolateral approach. So we start on the cresta and go down on the foot. We are centered on the fourth metatarsal base. And in the superficial layer, we cross the superficial peroneal nerve and we take care of it, and we have to luxate, mobilize, and luxate hit on the medial side. And this is the visualization of the approach. As you can see, we can take care to the fracture of the distal part of the tibia, and in particular the syndesmosis part. So if you have a Chapotello fracture, this is the most useful approach that you can use. In the anterolateral approach and in the anteromedial approach, you also have a manage of the talar dome. So if you have a osteochondral lesion or something else, this approach is very useful. About the direct approach to the malleoli, on the medial side we have a direct approach to the malleolus. This starts on the tip of the malleolus and go down and go up in the center of the tibia. In the anterior part of the approach there is the saphenous vein and saphenous nerve, and behind we have the tendon sheath of the tibialis posterior tendon. So take care of it, it's the same of the tibialis anterior tendon. So if you damage the sheath there is a major risk of surgical site infection. About the lateral approach to the fibula is very simple, centered on the fibula. You can also feel the head of the fibula, take a line and you go on it. If you can perform just one full thick flap, so go to the periosteum, and as you can see on the anterior part there is the branch of the superficial peroneal nerve, in particular if you need to extend on the diaphysis of the fibula. So more you go proximally, more there is the risk that you can damage the nerve. So take care of it. And behind we have the peroneal tendon, and behind the peroneal tendon there is the sural nerve. Is quite improbable, but if you go too much posterior, you can damage also the sural nerve. About the posterior approach to the ankle, this is a summary. First of all, we have the posterolateral approach. The incision is between the Achilles tendon and the fibula. During our incision, we cross a nerve, that is the sural nerve, taking your mind that the sural nerve is on the more or less 7 centimeters on the lateral side of the Achilles tendon from the calcaneus, are more or less about 5 centimeters on the incision of the posterolateral approach, and is 1 centimeters on the tip of the fibula. So these three positions help you to understand where is the sural nerve and avoid to damage. So during the posterolateral approach, first of all, we search the sural nerve, mobilize the sural nerve, and then we have different windows in the more deeper layer. We can go on the posterior part of the peroneal tendon. So to a posterolateral approach, you can put a lateral plate to the fibula. If you are more easy for you, you can also perform this. Another window is between the neurovascular bundle of the peroneus and the peroneus tendon. And we go between this one, and you can go in the posterior part of the fibula. The last window, we have to retract the flexor hallucis longus. We go to the Volkmann fragment, to the third malleolus. So you can manage also this part. And this is the exposure. As you can see, with the different window, you can put from the lateral of the fibula to the third malleolus. Then there is the posteromedial approach, is quite uncommon, but is start in the posterior part of the tibia and go down following the posterior tibialis tendon. As you can see, we have the neurovascular bundle, so after the incision of the fascia, take care of it. And also in the posteromedial approach, there are different windows. We can go medial to the posterior tibialis tendon. If you have a fracture of the posterior part of the medial malleolus, this is the better approach that you can use. But you can also go between the tendon and the neurovascular bundle to see the medial malleolus and the Volkmann fragment. Or if you want, you can go between the neurovascular bundle and flexor hallucis longus to see also the Volkmann fragment. And here there is the exposure. Then we have the calcaneal approach. There is one medial malleolus, approach to the calcaneus. This is the approach to the sustentaculum tali, and is the distal part of the posteromedial approach. So you also perform the distal part. We are behind the posterior tibialis tendon and neurovascular bundle. So we go behind this one, and we are on the substentaculum tali, the constant fragment in the calcaneus fracture. So this is a very limited indication. About the lateral approach is the most common. There is an L-shaped incision. We start between the Achilles tendon and the fibula. Take care in the upper part of the L-shaped incision to the sural nerve. We go down on the calcaneus body, and then we have a parallel incision to the fifth metatarsal. the most important thing is that we have to perform one full thickness flap. So to the skin, to the periosteum. And in this flap there is the sural nerve, the tibia, the peroneal tendon, and also some artery of the peroneal artery. So we go to the bone. We have to cut the retinaculum of the peroneal tendon to luxate it. And then we also have the calcaneofibula ligament that we can cut. So in this approach, you can extend it to the subtalar joint, and in the distal part also to the calcaneocuboidal joint. Take care in the distal part of the last branch of the sural nerve, so avoid the injury. This is a new approach, because it's a sinus tarsi approach. In the last year, is very useful in the most simple calcaneal fracture. We start to the tip of the fibula and go on the axis of the fourth metatarsal. We have the muscle of the extensor brevis that we can detach to the calcaneum, and with this approach we can see all the subtalar joint. If you have an arthroscope, you can see the subtalar joint made a percutaneous reduction, and there is some plate for the calcaneus to sustain the subtalar. So we avoid all the L-shaped incision. So this is a new approach to the calcaneal fracture, and also to the subtalar arthritis. About the talus, there is two approaches, anteromedial and anterolateral. It's very simple because it's the distal part of the anteromedial and anterolateral approach to the ankle. So we can just do the distal part. In anteromedial approach, we have to cross the saphenous vein and saphenous nerve, and in the deeper part, there is the talar neck. About the anterolateral, is also only the same incision for the ankle, but extended on the foot. We have the superficial peroneal nerve to avoid, and in the distal part, there is the sinus tarsi fat pad that we can detach, and we are on the talar neck. The last one is the Lisfranc joint. The classical approach to the Lisfranc joint is the dorsomedial and dorsolateral approach. The dorsomedial approach have an incision centered on the first ray axis. But if so we go between the tibialis anterior tendon and the extensor hallucis longus. But in the deeper layer, we can move between the tendon or to see the first cuneo metatarsal joint, but we can also move in the lateral part of the extensor hallucis longus. So with the more lateral approach in the deeper part, we can see better the Lisfranc ligament. So with just one approach of the skin, we can move on the first and on the second ray. About the dorsolateral approach is centered on the fourth cuboid metatarsal joint. We have to avoid the damage of the distal branch of the sural nerve, and we are on the extensor brevis, so we have to detach the muscle, and with this approach we can see very better the calcaneocuboidal joints and also the third cuneiform metatarsal joint. So with the dorsolateral and dorsomedial approach, we can see all the Lisfranc zone. In case that we have an involvement all of the Lisfranc, we can also use an extended approach. This is a very modern approach. It's a very big incision that go centered on the ankle and go on the second metatarsal to the phalanx. And with just one skin incision, we can move in the deeper layer in three different windows. So the first and the second window is the same of the dorsomedial approach. And there is a third window that we go between the extensor of the third finger to approach the third cuneo metatarsal joint. So with just one incision, we can manage all the dislocation of the first three rays. That is the more important because in the first three rays we need a rigid fixation, so we perform plate, screw, and so on. So with this extended approach, we can put three plates with no problem. And if we need, we can add a dorsolateral approach for the lateral side. Thank you.
Thanks to Dr. Vitiello. So this is the end of the morning session. Discussion can continue during the lunch. Anatomic theater starts at 1:30 at the anatomical Department of Anatomy. Thank you.
Thank you.
Да.